Hello and welcome to Talking Meds, a podcast from PrescQIPP, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at PrescQIPP. Hello and welcome to this episode of Talking Meds, where we're going to be talking about sleep disorders and the use of non-medicines interventions to help with this. This has been an issue for some time with the overprescribing of medicines for insomnia, with many high-profile campaigns to help us reduce the inappropriate use of hypnotics. One intervention that's gained prominence in the last few years is the use of CBTI, cognitive behavioural therapy for insomnia, and my guest today is an expert on that, Dr Dimitri Gavriloff. Dimitri is a clinical psychologist and sleep medicine specialist with extensive experience in assessing and treating a wide range of sleep disorders. He has experience of running an NHS tertiary care sleep medicine service and now works at the University of Oxford's Sleep and Circadian Neurosciences Institute, quite a mouthful, dividing his time between academic and research roles. Alongside his academic work, he's the director of Sleepwell Oxford, a sleep clinic and sleep medicine consultancy, and as a consultant in sleep medicine for Big Health Ltd. They're one of the companies who've created one of the digital insomnia treatments, Sleepio. So Dimitri, welcome. Thanks for joining us and thanks for giving us your time. This is a fascinating topic, I think, and one that there's a lot of interest in within the world of medicines and prescribing, actually. Because as I say, there's been lots and lots of controversy and campaigns over the years to try and reduce inappropriate use of hypnotics. So just a bit about you then. What brought you to be interested in sleep disorders?
Thanks so much, Jonathan, for the kind welcome, and it's a real pleasure to be here. So this is an area that's very dear to my heart, and it has been for a long time. But I think my interest clinically started when I did I did a conversion degree to psychology as a mature student. And we had lectures on circadian neuroscience, which I found interesting. I sort of found it interesting in a sort of curious, sort of documentary type, you watch something and you find it interesting. But it wasn't really until I began clinical practice as an assistant psychologist, training at the National Hospital for Rheumatic Diseases in Bath, where I was working in pain management. And saw many patients in our tertiary care, well, it was a national specialist team with pain disorders and with often complex mental health problems for whom sleep was a problem too. And these patients were struggling with a real range of problems. So everything from insomnia disorder to circadian rhythm problems to neuromuscular problems like periodic movement disorder and restless leg syndrome, obstructive sleep apnea. And what was fascinating to me was that these patients were extremely well catered for in every other respect. They had fantastic physio, fantastic mental health support. They had wonderful rheumatology care, nursing. They had everything that they really needed in every other domain, but they really weren't being routinely offered much in the way of support for their sleep. And that's not in any way a judgment on what the clinicians were providing. It's just a sort of a matter of fact statement about the way in which sleep is prioritized, I guess, within wider health settings. And so I was given an opportunity through my consultant at the time to input a little bit into the rehab program. And I began to be interested, particularly in sleep, because I thought, wow, this is an area that I'm interested in from a curiosity perspective, but it's something that isn't really being touched upon. And Jonathan, what was fascinating to me and what really catalyzed my interest was that I put a little bit of effort into low intensity behavioral interventions for people with insomnia, and we saw pretty good bang for our buck in terms of the response from patients. So actually patients really benefited from these evidence-based behavioral interventions that we put into place. And seeing the change that it made for them, that really galvanized my interest in the area. So that was my sort of start, if you like, and it's just kind of gone from there.
Brilliant. I can tell straight away the passion you have for this topic. It's lovely to see. It's interesting as well, talking about all the other services that are in place. One of the things we say a lot on Talking Meds when we're talking about shared decision making and consultations with patients is asking the question and finding out what is it that really matters to you here. And I bet you, if you asked people what really matters to them, a good night's sleep would be right at the top of the agenda on
Totally
that.
agree.
Because,
Totally agree.
I've had periods of time where my sleep has been disturbed, usually when involving small children when they were born. And after a while, it's absolutely debilitating.
Yes,
You just
absolutely.
cannot function and do the things that you want to do. So having a good night's sleep is so important for people, isn't it? So how do people end up struggling with getting a good night's sleep, Dimitri?
So it's a great question. And just like thinking about health more broadly, it's worth understanding from the outset that sleep is something that's a broad church of disorders. So when we think about health problems, there could be health problems in lots of different domains. It's analogous really to the way we might think about sleep. There may be sleep problems in lots of different domains. And so people develop these problems for lots of different reasons. So the pathophysiology or the etiology of the problems will be various. And if we think about that broad range of disorders, it goes from everything from insomnia, which we'll talk about, I'm sure, as we go, so difficulties falling asleep and staying asleep that impact function during the day, through to things like circadian rhythm sleep-wake disorders, things that are by and large related to our body clocks, so things like a circadian misalignment or an extreme preference. Things like shift work disorder fall into this bracket too, so where people's natural predisposition to a circadian preference is being in some way impacted negatively by their need to work a shift or their personal life requirements. You've got things then like neuromuscular disorders like periodic limb movement disorder and restless leg syndrome, parasomnias, things like sleepwalking and sleep terrors, nightmares, and things like REM sleep behavior disorder, which is a prodromal disorder associated with the development of multisystem atrophy, Parkinsonism, and Lewy body dementia. And you've got things like hypersomnias, narcolepsy, idiopathic hypersomnia, where people struggle to maintain wakefulness, all the way through to things like obstructive sleep apnea, which is, of course, very, very common and is a respiratory disorder. So in terms of the etiology, it's very, very broad. If we think about the way in which most of us will look at kind of disturbed sleep, we're tending to look at that through the lens of what we might call insomnia, either at a sub-syndromal level, a sort of a symptom-based level, or a diagnostic level. And the way in which this develops is going to depend on the individual, but by and large, we have a sort of a fairly nice way of thinking about the development of insomnia through a model called the 3Ps model, developed by Arthur Spillman back in the 80s. And that's that most of us will have a predisposition to some degree or another to disturbed sleep. And this will happen because of the fact that we're human. We have a mammalian nervous system. And so our sleep is disturbed in the context of, for example, stress or objective threat. We also have people for whom there's an increased risk, a demographic risk or an environmental risk or a genetic risk that increases their likelihood of developing insomnia. And so this is the first of the 3Ps. We call it this predisposing factors. The second of the 3Ps is called the precipitating factors. And as its name suggests, it's about a precipitant that kicks off a round of poor sleep. And so if we use the example that you and I share, Jonathan, in having had small children in the past, mine are getting a little bit older now, but still small enough to cause a bit of concern here, there, and everywhere. When we do get that disturbed sleep, it's often that's happening because of an external factor, like, for example, stress, or it might be exam pressure, it might be having small kids, or it might be having a period of illness. Sometimes it's not identifiable at all, but it's something that kicks off a round of poor sleep. And that transitions into what we call acute insomnia, an acute period of sleeplessness that by and large will right itself over time. So for the vast majority of us, it's not something that lingers for very long, and it tends to improve fairly quickly. For a subset of people, this 10% of the adult population of the UK, there will then happen to be a change in what we call the perpetuating factors. And these are the factors that keep insomnia stuck. So by and large, we think about these in two groups. So we think about cognitive perpetuating factors and behavioral perpetuating factors. And in short, what that means is that people change the way they think and feel about their sleep, and they change the things that they do in relation to their sleep. And they're doing this often without much thought. So it's something that happens fairly naturally, and it's certainly not their fault that it's happening. They're trying their best to manage the situation. But it's these changes to the automaticity of sleep that keep the problem stuck. And so when we think about insomnia, although there are many models upon which we can draw, this is a fairly straightforward model to talk through. It's generally through the lens of these perpetuating factors, the things that keep the problem stuck, that we understand insomnia to develop into a chronic problem.
Brilliant. That I like straightforward and simple for my brain, and I've not heard that three P's before, but that has absolutely crystallized it for me and completely explained the issue. I love that. So predisposing factors, those precipitating factors, and then the perpetuating factors, and it's the perpetuating factors that's when it becomes a chronic problem. If and I guess that's where CBT potentially comes in here, having that different way of thinking about things. So, based on that, then, what can people do to improve their sleep? What are the treatment options that we have?
Right. So again, going back to the previous point, there's a couple of things to pull apart here in the nuance. So the first thing to say is if we have a disorder that is it's not insomnia, for example, if we have obstructive sleep apnea, we go through the clinical workup and the diagnostic process, then we get an appropriate indicated treatment. And in that case, it might be anything from adenotonsillectomy to a mandibular advancement device, or perhaps even a CPAP, continued positive airway pressure. So these kinds of things are indicated for that particular problem. And the same is going to be true for all the rest of the diagnoses. So everything from, as I say, from the diagnostic manual that I ran through earlier. When it comes to thinking about insomnia, we have, as you mentioned, CBTI. So CBTI is the first line recommended treatment in all the guidelines, really. It's certainly in the NICE guidelines, but also in the European guidelines, the American guidelines. And the reason why it makes sense to target insomnia using a cognitive behavioral approach is particularly because we want to target those perpetuating factors that keep the problem stuck. So by and large, the way we approach insomnia using a CBT approach would be using the modules that sit within this broad treatment approach that look at targeting a cognitive therapy for a cognitive problem, a behavioral therapy for a behavioral problem. And because it's something that's modular, because it's not something that is a uniform treatment, you can switch out bits of the treatment, relating to the problem that the person has, in order to make it personalized, in order to make it make sense for them. And so we can think of CBTI as a bit like a formulary upon which we can draw with different drugs at different doses given in different regimens. And this is why I think when we use CBTI, we have to think of it as a treatment approach rather than thinking of it as a unidimensional treatment, which is where sometimes we can get a bit stuck. But if we think about clinical practice more broadly, or perhaps more routinely, most of the time, when a patient says that they have trouble with sleep, they'll be offered something that's rather euphemistically called sleep hygiene. And sleep hygiene is not a dirty word. It's very important to understand that they're often good pieces of advice. But sleep hygiene is not an indicated treatment for any sleep disorder. And that's very important to understand. It's good advice. It's a kind of a bit like an analogy might be, if I were to turn up at the GP with gastroenteritis and the GP said to me, well, just eat 5 a day. Eating 5 a day is good advice. Well, yeah, that notwithstanding, I still need a treatment for my gastroenteritis. So the importance of the conversation here is not to dismiss the value of this general advice, but to recognize that there are disorders that require indicated treatments, very specific treatments that will ameliorate the discomfort that the person's going through. When we think about sleep hygiene more broadly, it's not a standardized thing. So if you look at a sleep hygiene leaflet in John O'Groats and down in the Lizard Peninsula in Cornwall, you'll see that they're probably very different in lots of different ways. There'll be different ways of placing emphasis on things. They may be broadly aligned in other respects, but they won't be exactly the same. So what we can think about, and what might be helpful to think about, is what Professor Colin Espy, who's our professor of sleep medicine here at the University of Oxford, has deemed the 5 principles of good sleep health. And this is something that refers to valuing sleep, prioritizing sleep, personalizing sleep, trusting sleep, and protecting sleep. And more can be found on those five principles through the Sleep Charity website, which people can go to online. And this is kind of looking in a sort of almost prophylactic way at trying to help people understand the value of sleep, such that we can actually make sure that we look after it appropriately in the way we might do for, say, cardiovascular health or for nutrition.
Yeah, again, I really like that. I mean, I've been involved in writing some sort of like sleep hygiene guides in the past, good sleep guides, and it's always been something a bit like motherhood and apple pie. It's all very sensible stuff. And I think the analogy with cardiovascular disease is a good one. If you, I don't know, have a heart attack or whatever, then clearly you need to eat healthily and exercise, but you also need other things as well to try and help you with that. The other thing I've noticed is you like your P's, don't you, in this world? Three P's and five P's, as in the five principles of good sleep health. But again, really, really helpful and useful. So, so just in terms of CBTI, then, how do people go about accessing it in the UK? I get this. I guess this is the thorny question, and it's like this with a lot of sort of mental health disorders. So the nice guideline on depression, for example, indicates talking therapies and CBT for depression. The problem is getting access to it, isn't
Yes.
it?
Yeah,
So,
that's absolutely right.
so what do people do about this, Dimitri?
Well, so the problem is getting access to it. That's exactly right. And I feel like this is uh, the crux around which so much turns, really. The the thing about CBTI is that it is often available in a sort of very patchy way across the UK. And so if we think about how we can access CBTI, remember it's a broad treatment approach, not a unidimensional treatment. We might be able to access it through, for example, self-help materials. There was a push a while ago for books on prescription, for example, where books like Overcoming Insomnia and Sleep Problems was made available. And that's a great book for self-help. But actually, if we think about it from a step care perspective, that might be okay for some people who would kind of benefit from it, maybe lower down on the step care um, hierarchy. But as we get further up, and we're thinking about things like face-to-face access or group access, you're really looking to psychological therapy services typically, or specialist insomnia services. And that there really isn't any standard offering from the NHS across the UK in a very uniform way for this. So you may be very lucky, and that in your postcode or in your area, in your patch, your um, uh, um, particular region, there's access to something face to face, or it may be a group or it may be telemedicine. There may also be the option if you're someone within the referral footprint for accessing a specialist insomnia treatment clinic, and there are several throughout the UK again, but not in any kind of uniform fashion. There's London and down in the south tends to be better provision than elsewhere. But the point is that there's going to be far more need if we think about the population prevalence of insomnia for help than is currently available through face-to-face NHS services. And what we'd like to do, or what I'm very keen on doing is, and part of my work at the University of Oxford is involved in training people up so that we can increase the degree to which we're able to provide that through the NHS. But even if we were to do that, tenfold, 15-fold, 20-fold, we still probably wouldn't meet the demand because there's a huge demand out there. And so we have to look at other ways in which CBTI can be offered. So that's meant a push towards what's called digital treatments or digital therapeutics that include a range of different digital treatments for insomnia that are out there. And currently, depending on where you are in the UK, you could have access to CBT digitally, so through the internet or through a particular program. And by and large, that's something that you'll have to, again, it'll be based on where you are and who and which patch you are. Currently in Scotland, there is digital access for free at the point of care. to digital CBT for insomnia for all Scottish residents. But that's not the same elsewhere throughout the UK.
Yes, so the digital apps that were that are available for this, there's been some controversy, hasn't there, around the access to them over the past few years. So in terms of future developments, then, where do you see that all going in terms of access to things like digital CBTI or some of the other interventions that potentially are on the horizon?
So I think again thinking and I've been talking about this recently with a wider European group about stepped care provision of CBTI. Quite clearly, there is a huge demand for effective, evidence-based insomnia treatment that's first line treatment. So we're talking here about CBTI rather than about drug treatments, which are also indicated, but as second line treatments. The most important thing to understand is that in order to meet that need, there needs to be a population scale approach that's appropriate. And that to me looks as if it's something that will probably come through the digital sphere because that's the way to meet the need the most effectively. I think the other thing we have to think about is building up what we have available for people in the NHS in terms of face-to-face and perhaps group settings, and then thinking also carefully about specialist care too. So if we come back to that step care model, not everybody will need to see a specialist. Not everyone will need to see someone right at the top of the hierarchy in the same way as they wouldn't for any other set of problems, say mental health by analogy. So at step four, perhaps we have these people for whom there's very complex insomnia in the context of other sleep disorders, perhaps, or the more complex mental health problems. And it's the case complexity here that is the thing that's determining where they sit in the spectrum. Development of that step care model is very, very important, and everyone has a part to play there. So just thinking about the audience here. So I'm a clinical psychologist, and my role within what I've done in the past has been often to be the specialist, to be right at the top in terms of providing CBTI. But I've also worked very closely with everyone from CBT therapists to GPs to pharmacy colleagues to thinking about nursing staff and all kinds of colleagues from all different domains within the NHS to try and make sure that whatever they can do within their respective patch, within their respective remits, they can also provide because they don't have to necessarily be specialists in this area. They need to know a little bit more, perhaps, I mean, the first thing to say is none of us get trained in this routinely, do we? No matter who you are clinically, we don't get core training in sleep, which is ironic given just how important it is, or becoming more obvious how important it is. So what we want to try and do is to make sure that people are given the tools to then go on and to be able to provide whatever they can within their respective remits. And thinking about pharmacy colleagues particularly, there's no reason why pharmacists can't be providing useful evidence-based advice in a way that doesn't mean that they have to resort to a prescription, particularly for a first line treatment. So I think for me, in terms of future developments, it's building that step care model and integrating everyone clinically within it. We're not creating specialist insomnia services everywhere. What we're doing is we're having a step care approach whereby we can all fit in, we can all contribute to managing one of the most prevalent problems that we have in our patients.
No, I think that's exactly right, Dimitri. I really like that. Just that sort of healthcare professionals becoming more aware of exactly what it is they can provide. It doesn't have to necessarily go through a specialist centre.
Exactly,
It could
exactly.
potentially be delivered by any suitably trained and competent healthcare professional. It's interesting though, isn't it? You can see why people struggle to reduce their inappropriate prescribing of hypnotics, can't you?
Yeah,
It's
yeah,
very similar to antidepressants, isn't it? Somebody comes to see you in a primary care setting, and you think, well, what can I do for this person? I could refer them to a specialist clinic, but the waiting list is going to be ages because, as you said, demand outstrips the provision. Um, the, there isn't any access on the NHS to the digital apps within England. There is in some other parts of the country, but not within England. So, what do I do here? I know what I'll do. I'll write a prescription for a hypnotic.
Yes,
because at least that's giving something to someone. You can see how easy that is. And if you want to change that behavior, what you need to do is make that a more difficult option for people than the other options that are perhaps more useful and evidence-based. So I do think there is definitely something about access to those because I remember when I worked at NICE, the evidence for these things is fairly good in
it's
terms of their
excellent. Yeah, it's
effectiveness. It's
very
really
robust.
good.
Yeah.
And it's still very frustrating that 3 or 4 years down the line that we still haven't got that provision in the NHS. So
No, it's disappointing, but we're still working towards it. I think the thing to just really reinforce what you've just said, which I think is so important, is that these aren't sort of naive or negligent clinicians doing this. These are clinicians who care for their patients, who want to provide something to the human being that's suffering in front of them, and so they reach for whatever they have at their disposal. But in just the same way as if you had a tradesman who just only had a hammer and a screwdriver but no other tools, didn't have a saw or anything else, they might have to start hacking up pieces of wood with a hammer because that's all they've got. It's not the best tool for the job. So the point here is that it's not the problem of the clinician. The clinician is doing the best with what they've got. Let's start with that premise.
absolutely.
And then let's try and help provision people with what they really need, which is to say education in sleep and sleep medicine. Doesn't have to be particularly deep, but it needs to be comprehensive and it needs to be relevant to the patient population that they're seeing and they're treating. And the second thing is then providing access, as you say, to the treatments that they need. So if we think about this outside the realm of insomnia, it's going to be things like attention to, for example, iron profiles when thinking about restless leg syndrome, for example, or that kind of thing, or thinking about screening for obstructive sleep apnea in people for whom there's an increased risk, that kind of thing. So these are things that people can do, they can put into practice, and that starts the ball rolling. But the more that we build momentum within the wider clinical workforce, the more likely these things are going to change.
Yeah, and again, just to add to that as well, I've got lots of colleagues who work in menopause services as well. And one of the things that they often see is women who are going through either perimenopause or menopause who present with symptoms but are not treated with HRT, but are prescribed a hypnotic to help with their sleep. And actually, what they probably need is a proper investigation in terms of their menopause status and actually to see whether HRT is appropriate here.
Yeah, so menopause is a really interesting area for, I mean, speaking as a man here with obviously no experience firsthand, but the point is that this is something that women have been, this is part of being a woman, and it has always been part of being a woman. We're only just beginning to talk about it sort of in a very comprehensive way, and it's great that we are, but we also have to do so in a very comprehensive way. Think about the relationship of sleep and the menopause, nutrition. All these different domains kind of have to come together. And sleep is often disturbed during the menopause, just as an example, as it is during lots of other parts of people's lives and in relation to different disorders. So ignoring the sleep bit is doing a disservice to how we can help someone in a particular way. So in relation to, say, the menopause, or to aging, or to, say, dementia care, or whatever it might be.
Yeah, absolutely. Dimitri, that's been good. Just to finish off then, we always like to do the kind of the what three things. So what three things can people be doing about either their own sleep or when helping others who are struggling with sleep?
So the first thing to do, and I make a point of saying this all the time, is to actually acknowledge the problem as something that's worth doing something about. Speaking as British people, perhaps we're quite good at just, stiff upper lip, pushing through it. And sleep is an area in which people, I think, historically have done that quite a bit. There's almost a kind of bravado about saying, well, I only got, 4 or 5 hours sleep last night. We wouldn't say I only had one glass of water yesterday. In fact, I didn't drink anything at all yesterday. I only had a sandwich to eat yesterday. We wouldn't do that. That's a strange thing to do. Why is it that we do it with sleep? So let's start by acknowledging that there's a problem, if there's a problem, and say, maybe I'm not getting enough sleep, and maybe this is something that's impacting on my, my immune system, or my mood, or my, cognitive capabilities, etc. And acknowledging that might mean talking to your GP, might mean going to your pharmacist and having a conversation, but it certainly doesn't mean struggling on with it and just ignoring the problem. So that's the first thing. The second thing is that if you have a problem and you recognize it as such, getting it identified and coming up with a plan is very, very important, and sticking with that plan. So if we think about, for example, CBTI is great to read about, but unless you put it into practice, it's not going to actually make any difference. So thinking, for example, about coming up with, if you went to the GP and you were prescribed a course of antibiotics, if you only took day 1, day 5, and then didn't bother with the rest, you're not going to get the full benefit of the course of treatment. So in the same way, if you come up with a plan for your sleep problem, see it through, make sure that you're putting it into practice. And that's something that can be difficult for some people because of the way in which insufficient sleep or poor sleep makes us feel. So maybe getting some support with that through a healthcare professional, through a friend or a colleague, because that's going to make the biggest difference. I think the third thing is just to think about sleep in a much broader sense. So rather than thinking about it in a diagnostic sense, think about it perhaps through what I mentioned earlier, this Professor Espy's 5 principles of good sleep health, and maybe thinking about wider sleep education. There's a lot that we can do to recognize just how important sleep health is across sort of all domains of human function and performance and wellness more broadly. The thing to understand here is that we have an ability as advocates or as people who are interested in this to talk about it, to push for it, to educate, to do all these kinds of things, and we can do that in a fairly comprehensive way. We can signpost people to good information, to evidence-based information, to scientifically valid information, and this is the kind of thing that I think we can encourage people to do. Broadly speaking, in terms of sleep. So whether you're a clinical professional, whether you're a husband, a wife, a son, or a daughter, doing that in whatever small way you can is going to be important.
That's really good. Superb. Thanks for that, Dimitri. I think the other thing to say is we've done quite a bit of work here at PrescQIPP on insomnia as well. There's quite a lot of resources that we've done. We've done masterclasses on this as well. So we'll put some links in the show notes to those materials. We'll put links to the 3 Ps and the 5 Ps, which I really like as well, and some of the other resources that are available for people. Dimitri, can I just say thanks so much for that? As I said at the start, your passion for this comes across loud and clear, and I think that really helps to get this message across about what people can do about this area, this tricky area that we will all come across, I think, at some point in our lives, either as healthcare professionals or indeed as individuals, either ourselves or with loved ones or friends and family. Insomnia and the related conditions are so prevalent, aren't they? But it does sound to me that there is something we can do about this with a little bit of effort on our side. So,
yes,
yeah.
absolutely, and help each other, which is why we do the jobs that we do. But Jonathan, thank you so much for having me and for having the conversation, because it's been really enjoyable.
Brilliant. Thanks, Dimitri. Right, cheers, guys. We'll see you again soon. We hope you enjoyed today's podcast, and we'll see you in a couple of weeks for the next episode of Talking Meds from PrescQIPP, engaging conversations about medicines-related dilemmas. Please follow us on LinkedIn and Blue Sky to join in with the discussions, and email us on talkingmeds@prescripp.info with your feedback or suggestions for future topics or guests. Please don't forget to register for access to the PrescQIPP website for all of our excellent resources.